we're already behind time. So going back to what was spoken since morning, so this is typically the journey of a patient with a severe TR, a very sick patient, overloaded, congested, very tired, a lot of fatigue, and then you have these investigations available to you, starting from TT to the other imaging modalities, and then you have the heart team which is there to find out how best you can do something for the patient, and then you have the treatment choices in terms of medical management, and you have surgery, and then you have the catheter interventions right now. And what are the targets for the transcatheter interventions? One would be looking at in terms of the annulus, in terms of the leaflet, and then the heterotropic devices, and then you have the coaptation enhancement, and then the replacement itself. So you have a lot of options here. Each one has its pluses and minuses, and then you have occasions where it needs to be done. So typically for any of these procedures, you should have significant TR, RV changes especially should be looked into, and patient symptomatic due to right heart disease, and then in terms of transcatheter interventions, you need to have appropriate surgical risk, and then the structurally favorable anatomy to do an intervention or a repair. So in terms of surgical repair, so echo has this role of looking at the severity. So you've seen through morning what are the various parameters, looking at the IVC, especially how much of congestion it is causing, and how much of problems in terms of the edema. And then the mechanism is very important to address what the problem is, what the TR is due to. And the key point is also to look at the RV size and then also the RV function, because more the RV function deteriorates, worse will be the prognosis and the difficulties later. And as far as surgery is concerned, this old parameter not really reliable but still very much in use. You have the annular sizing of 40 millimeters. And then you have these various views which you all look through, and then you have the various grades of TR, and you also have to look at the parameters in terms of the hepatic vein, the flow reversal also, and then the 3D to some extent provides you some initial insight as to how the tricuspid valve looks like, or the window is good. And you have these newer tools now in terms of the valve quantification, so where one can look at the annular sizing a little better, and this is a little better because in terms of the sometimes when you have an elliptical annulus, you might have a wrong measurement of 40 millimeters, and typically surgeons always tell us that you didn't really tell us the right size and we found it different. So that's because of the shape of the annulus itself. So the 3D valve quantification tool helps to make accurate. Now moving on to TTL. So you have this table which is there, not going to go too much into it. It's just that what is ideal, you have the great window for it, and that's the perfect patient. And then you have the intermediate one where you have these numbers in terms of the gap, and then you're also looking at the quality of the leaflets, and then looking at the lead which is there, and also the amount of the PA pressure. And based on this, one decides like it's an ideal patient or it's not at all possible, or in between. It depends on case to case, and the heart takes the decision. Now the annular remodeling itself, so what is happening in TTL is that you have the anterior leaflet and the posterior leaflet. So you have the outward remodeling. So when the clips are being put in place, and then you're trying to get the leaflets together, so there's going to be an inward remodeling, and that's the whole point of it. So that's how to control and to minimize and bring down the TR over there. So the procedure planning itself, so it's just a lot of procedures. So I just want to speak on some main points. So looking at the anatomy, looking at the mechanism of the TR, and then establishing the severity and the RV and then the IVC, and then associated pathology. Based on this, one comes to a decision whether the TTL is feasible or not. Now the views, again, I'm going to rush through because there are other entities also I have to look into in the shortage of time. So you have this classic protocol where you start from high and go down to mid and then low esophageal views. So the idea is to look at the leaflets. So very high, you're going to look at the anterior tricuspid leaflet and then the septal leaflet. As you push the probe further down, you start to look at the posterior tricuspid leaflet, especially when you have the Cowley sinus which is appearing. That means that you're more likely to be hitting the posterior tricuspid leaflet. And then you have the biplane views where you have explains, and every time the cursor sits on a particular leaflet, that means you have that leaflet which you're going to look at. For example, you look at the bottom image where it is focusing on the PTL, and what you see on the other side is the cut of the posterior tricuspid leaflet. You can look at the quality of the leaflet and any other identifiable features which you would like to look into. And here you can see that it's right in the center of the coarctation, and then that is find out how the coarctation is going to look like. And again, here's an example of where the cut is going. It's right in the center, and then you can see that the TR which is there. So you swing the cursor back and forth, and then try to find out where the maximal TR is and in which commissure it is. And then 3D gives you the perspective of what the morphology of leaflets is. And you always were comfortable with the tri-leaflet, the tricuspid valve, and then where the jets are originating. It gives you a very good spatial understanding, not just the anatomy, but also where the jet is coming from. And coming back to the mid and the low esophageal views. So again, here you have the influent view and the inflow and the outflow view. So this is typically somewhere around 60-70 degrees, and then the cursor here is moved back and forth. The first image shows you that the cursor is on the most medial, and what you're going to see here is the anterior tricuspid leaflet on the other side and the septal leaflet. And then depending on where it is, either you're at the commissure or at the margins, and then on the other side you can see that it's moved to the far side. So there you're looking at the posterior the commissure, the septal commissure, and if you bring it towards the tip of the leaflet, so that means you're at the margin of the leaflets. And here you investigate the TR where it is coming from, swinging it back and forth. And another important view is the transgastric view. So this is mandatory, and it can be challenging sometimes. So you need to get all the three leaflets. So one towards the probe is always going to be the posterior tricuspid leaflet, and the one towards the septum is a septal leaflet, and the opposite to the one is the anterior tricuspid leaflet. So here you can see that the jet is coming in the middle, extending to the septal anterior commissure, and predominantly, and to some extent it goes towards the septal and the posterior commissure also. So this is where the identification is done and the planning is done in terms of how to put where to put the clip. And to some extent the deep transgastric also helps in looking at the leaflets far down. Now the value of 3D is also what looks like a TR in the leaflet. You can also identify by 3D to what type of leaflet it is. So you can see that here it is a bicuspid leaflet, and the challenges are more. So this is where the understanding is going to be. And another example of how the tricuspid leaflet chain has this different variations and types, which you saw in the morning. So this is a 4 leaflet, and these are challenging ones, and this gives you an insight, and that is where the value of 3D is going to be, not just in looking at the place where it is coming from, but also understand the morphology of the tricuspid leaflet. And in terms of the CID, so you have the leads. So ideally you want the leads to be in the commissure, but sometimes it sticks to the leaflet itself. It causes impinging. So it's very important to look at whenever there's a significant TR, if there's a lead, to identify whether the lead is just an innocent bystander and there's another mechanism, or the lead itself is the cause which was told to you in the morning. So again here the spatial understanding and the information that is obtained from 3D is very valuable. So you have this protocol of different images. So this is typically T. So you start from mid, high, and you go all the way down. And there are various ways of looking at it, as I showed you. And the TT also plays a very important role, and it has got its own standardized views, which you saw in the morning. So again, to basically see the same thing and from a transthoracic view. Sometimes, as was mentioned in the morning, the T itself may not be that sort of helpful. So here the TT can be very, very helpful. Especially if there's a good window, you can get better information and even images also. Now in terms of procedural guidance, it's the same thing for MTL. So you go through this, except that there's no septal puncture, and then you go through this sequence. It's a very standardized protocol, and then you go all the way down, and then you finish the procedure. So that is about it. So here's an example of how the image looks like. So here you have the TR which is there in the center and extending predominantly towards the anterior and septal commissure, and to some extent towards the septal and the posterior commissure. So the idea was to clip the septal and the anterior over there, and basic measurements. were done. So this is not an ideal one, but just these were taken and they're showing it to you, and then you look at the gradients. So this, you keep it like baseline measurement. And then you look at the reversal. So again, you're going to look at this reversal later once the clip is made and see how much the reversal has improved. And the 3D, again, this is just showing how it can vary sometimes. It may not be very good in some patients, so you have to sort of adjust to what is available to you. And then here, just briefly the steps here. So the guide comes in. So you just like you have an aorta hugger in the MTL, you can have a septal hugger, and then you use this inflow view, and you try to get to see the trajectory of the clip as it is brought down, and this is above the leaflet, and then gradually as it is maneuvered, you look at the opposite image, and then you make sure that you're going into the right area, the right commissure, so whether it is the posterior or the anterior, and then you do these specific adjustments over there. And then once that is done, the scene shifts to below the leaflets over there, and then the idea is to make sure that the alignment is good. So after getting the trajectory, and then the leaflets are going to be captured on the arms. And then after much maneuvering, then you start to see that the leaflets are well in position, and then the clip is closed, and then now to look at the rest of the TR. So it looked like the TR was still there, and then it was still going to be significant. As you can see that the clip is in the far end of the commissure, so there was space enough for the second clip also to be put in. And then looking at the TR, again quite significant, so another clip was planned here, and then again brought next to the second clip. And the idea is again to come towards the orifice, and the clip is now being put into place with a similar approach. And what you see is the TR initially, and then the TR comes down here. So some amount of residual TR was acceptable, and at this point, again looking at the transgastric, we stabilized the clips and where it was in the right position, the TR came down. So this is just a way of summarizing very briefly of how the TTR is done, and how it can be guided in terms of procedure. And these are 3D images just to show, nothing great about it, but just to understand the clips are side to side. Now the other type of the transcatheter one is the TTVR. So this is the orthotopic implant, and again here the imaging is primarily pre-assessment here in terms of assessment of valve dysfunction. You want to establish the valve dysfunction, the TRs especially, and then look at the RV function and the size of the annulus, PA pressure. So this is again a standardized way of looking at it. So it's a lot of help in terms of trying to find out how bad the valve is. So this is something which was done many years ago, so I just brought it out for this occasion, and then you can see that there's a lot of valve dysfunction over there, establish it, but more importantly the CT plays a big role here in trying to understand the annulus size, looking at the calcification, and looking at the distance of the coronary artery from the annulus, and there are many points which are very valuable and important on CT itself. And then after that the planning is done, and then the valve was deployed here. So it was stable, but post deployment later on, a few days later, there was a little bit of leak over there, and then this continued to increase a little bit. So not an optimal one, but this again is a demonstration of how the TTVR is done. So it's still early days here, very few TTVRs are done. So this is one of the older ones done on compassionate growth. Now coming to the cable one, the heterotropic implant. So here again establishing significant TR here. So the idea of cable implant is not to bring down the TR, but to reduce the influx, the reflux of the TR into the IVC and try to reduce the congestion over here. So this is a very classic patient. You have a very prominent JVP, and then you have a leaflet which is seen on 3D. And here again, the Doppler assessment in terms of the SPC and looking at the IVC flow, and then looking at the VTI, and then you do it pre and post. And then again at the hepatic vein also, you try to look at what is the amount of flow that goes back in and to see the amount of reversal. And it's very important to understand the anatomy here. So looking at the SPC and the IVC, and in terms of the pulmonary artery and the way the deployment is going to take place. So CT is going to play a major role here. And the measurements are done on the CT, and looking at the SVC and IVC measurements. And this is an example of post-deployment, and again looking at the amount of flow that is coming back in, so both at the SVC and the IVC, and looking at the stability and then the depth of the cable valve over there. And in this particular patient, there was some amount of leak over there, and that was acceptable. So to conclude, in a very brief way, so these are the procedures that are available in terms of both surgery and as well as transcatheter, and each procedure has got its own way of identifying what is required, and then ultimately there's a very integrated way of approaching as far as whether it's surgery and especially for transcatheter, and each imaging modality has its pluses and minuses, so we combine together and then use this algorithm and decide where this is going to be done. And also the use of intracardiac echo also has its own role, and in our country, in our situation, it has a very limited role due to various reasons. So thank you.
Thank you, Dr. Sathish Govind.